All right, thank you so much for joining us today. We're now going to go ahead and go through some of this diagnoses on respiratory system disorders. Don't forget, we went through the guideline already. We went through, some medications already. We went through ways on how we can handle this using the ADPI process. We're now going to deal with the main thing that students tend to struggle with, which is diagnosis. So you will see me going through this content, what diagnosis is similar to it, how do you separate it from those ones that are similar to it, and then on the bottom you will see me going over what flashcards to help us kind of seal the deal and let it sink in. And then you're going to see me coming up with mnemonics to kind of help you remember it. It's called Auntie Cindy Paints Pictures to Appreciate Beautiful Paintings. I will be going over that as well. So now let's get started with asthma. When we talk about asthma, what are we talking about? And by the way, speaking here, Dr. Kehinde, ELISHA, founder of FNP Certification Academy. To reach us, nurse-coach@gmail.com or info@npcertificationacademy.com. We are going through what? The respiratory disorders and treatment today, just in a way for us to seal it and reinforce it and make it, easier as a group. So asthma is the very first one we're going to talk about. I asked you earlier before I show my slide about key symptoms. You don't seem to have any problem much with asthma. Wheezing, dyspnea, chest tightness, cough, allergic history. Triggers are usually exercise and allergies. Now, what is the benefit? What is the essence of these keywords? Now, this keyword is supposed to be what? Your guide on the exam to say, hey, they're going to try to point you there that, hey, face this direction, don't be facing there. Because there are other things that also look like asthma, like what? That is the COPD, which is chronic obstructive pulmonary disease, vocal cord dysfunction, congestive heart failure. These are things that are synonymous, that look like it, that overlap it, in some ways. So how do they really overlap? So COPD, first of all, is irreversible. We also have some breathing issues with it. It's possible to actually also wheeze on COPD too. Anytime you have narrowing airway, wheezing is possible. Okay, but wheezing, the wheezing itself, though, is more chronic with what? With asthma. But when you start saying what irreversible and progressive, you should connect with the dots with the fact that it has to be COPD. Now, what about the vocal cord dysfunction? That one will involve what? Inappropriate vocal cord closure. It is going to involve what? Inappropriate vocal cord closure. It's going to involve this key symptom right here. Now, I don't know why my eyes is not seeing for some reason. I couldn't find my pen for a moment. Now, what about the, and CHF is what? Linked with fluid retention. So with CHF, you think fluid. With vocal cord dysfunction, you think what? Inappropriate closure. With COPD, you think, okay, it is irreversible and progressive. Listen, they're going to put this keyword also on your test question. Do we have any question here? Do you feel like, okay, I got this? If you feel like you got this, please type yes in the chat. If you have to pause this video and come back and listen to it, come back and get the symptoms right. They will never give you asthma on the exam like that. They won't throw it at your face. They will describe the symptom and expect you to know it. Now let's go ahead and go to the next one. That is the chronic obstructive pulmonary disease. So with chronic obstructive pulmonary disease, smoking history, chronic cough, sputum, progressive dyspnea, barrel, chest. So let me hold on to this because it's too much. We can't really know all of the symptom. So what am I going to hold on to? I'm going to hold on to smoking history. I'm going to hold on to barrel chest. Why am I not going to hold on to cough too much? I wouldn't hold on to cough because there are coughs with anything else. But when it says chronic cough, that is not uncommon with our COPDers, right? Now, progressive dyspnea, it is everything about COPD is progressive. Just slowly gets worse. Wheezing, like I told you, we also see wheezing, but that is not the chronicity of it though. That kind of shows up maybe at the later. It's not really at the beginning. Now, what does it look like? What else presents just like COPD? Asthma, bronchitis, interstitial lung disease. So what actually separates this differential from the real diagnosis? Guess what? If you get a question on COPD, you know what's going to happen? They will give you all of this as what? As multiple choice. Your multiple choice is always your differential. So listen, it is always important to understand the difference between your differential and your main diagnosis so that you don't fall trap on the exam. So with asthma, it is in fact reversible. With COPD, it is in fact irreversible. That is a major difference between the two. Now, Bronchitis has what? Irreversible bronchial dilation. It is an irreversible bronchial dilation. What about the ILD? We're like, what in the world? What is ILD? That is the interstitial lung disease that we just spoke about seconds ago. That one, you will see some kind of restrictive pattern. Now, how would you see this? Through our tools that we normally use in assessing and measuring volumes and lungs and stuff. So that is how you're going to see some restrictive patterns. It is not something that you see physically with your eyes. This is happening all in the lungs. Now, do we all get that straight? If I ask you right now, what is the differential for asthma? Would you tell me? It is COPD. It is vocal cord dysfunction and it's congestive heart failure. If I ask you what is the differential for chronic asthma, it is for COPD, it is asthma, it is bronchitis, it is ILD. Okay, so now we're going to move on to the next one is pneumonia. So with pneumonia, what do we say with pneumonia? Cough with sputum, fever, pleuritic chest pain, dyspnea, crackles, consolidation on chest x-ray. What do we see with pneumonia? What makes it stand out? What makes it unique? Though, if we think this is a lot, we need to think of, okay, what is the genesis of pneumonia? We know it's usually what? A bacterial infection. If it's a bacterial infection, what are we expected to see? We're going to definitely see fever. And then when we see fever, what else do we see on x-ray? A consolidation on chest x-ray. That one is frequently written in your test, so you're going to pick it up. So what else can this look like though? Acute bronchitis, pulmonary embolism, and lung cancer. So this is scary. Somebody just tell you have cancer, you know what I mean? Can you imagine that? But anyway, that is the purpose of working things up. So if something look like cancer, it doesn't mean it's cancer. If something look like embolism, it doesn't mean it's embolism, because we have things that overlap when it comes to symptom. So what sets this apart from our pneumonia? Bronchitis, they lack consolidation. Pneumonia will have consolidation. So pneumonia will consolidate. Just think of our bacteria, they work as a team and they consolidate. They work together. I'm not sure that's a good example, but anything to help you keep it in. Now, what about PE as sudden onset with risk factors, and lung cancer present with weight loss and imaging findings like masses. So lung cancer, we know what lung cancer is. Your weight loss, though, will not be out of place. That is the first thing that we tend to focus on with that. If I ask you right now, what are the differential for pneumonia? You're going to say acute bronchitis, pulmonary embolus, and lung cancer. And if you want to be like, okay, I like mnemonics, there's a mnemonic for this one, you can say, okay, this one is looking like a PAL, like a PAL for pneumonia. PAL for pneumonia will mean what? Pulmonary embolism, acute bronchitis, and lung cancer. Now, what about pulmonary embolism itself? It's a sudden chest pain, dyspnea, tachypnea, tachycardia, hemoptysis, risk factors, example, immobilization. So how do you describe pulmonary embolism in a nutshell? If you're like, okay, this is too much, I want to pick something easy and fast, definitely sudden chest pain. Dyspnea is kind of, sudden as well, because we don't know the clot was going to escape and go to the lungs, right? As you're struggling to breathe, what's likely going to go with it? You're likely going to, it's going to be obvious, but then what is going to go with it? You're going to be, your heart rate will start taking a hit. You may start getting tachycardia. And of course, blood is sputum is also one of the things that we see. However, if you want to hold on to just 3 things that will clue you in for sure: sudden chest pain, sudden dyspnea, tachypnea, tachycardia, pulmonary embolism, boom, you're done. Now, what does it look like though? Pneumothorax, myocardial infarction, aortic dissection. So now look, what if I ask you now that, what now separates them? Because you have to know what separates them. You don't want to know what it look like. I don't know, okay, I know it look like pneumothorax, I know it look like MI, I know it look like aortic dissection. I think it's half knowledge if you don't know what separates them, if you don't know what makes them different. So pneumothorax will involve what? Hyperresonance. MI present with radiating chest pain, and aortic dissection causes what? Severe pain radiating to the back. So listen, pneumothorax will be hyperresonance. Pneumothorax will be hyperresonance. Take an empty can and beat it up it's going to be high-power. It's going to be high-pitched, something like high-pitched kind of a thing, high-power resonance. So when we say pneumothorax, what does it really mean? What does pneumothorax mean? Does anybody know it's connected with pneumothorax? Pneumothorax, what does it really mean? Okay, hemothorax, what does it mean? Sorry? I'm waiting for answers though. I gave you the clue already. Hemo and pneumo.
So pneumo is air infiltration.
Excellent.
Yes, hemo is
And hemo is blood. That's it. That's all it is. So now, if hemo is air, so that's take an empty can beside you right now, beat it up, right? As hyper resonance. Now, MI will therefore present with what? Radiating chest pain. That will always be a description of MI. And aortic dissection causes what? Severe pain radiating to the back. If somebody have it, that will also be your exam. If they give you an aortic dissection question, the pain will radiate to the back. So now, the first step, if you're like, you know what, the difference is too much for me right now, how can I take it step by step? If this is too much for you and you're just now, you get overwhelmed with respiratory system, do this, okay? Go ahead and say, okay, I'm just going to focus on the definition. Let me even know what pulmonary embolism look like. And that's fine. You can do that for like 2-3 days. The third day, come and say, okay, what actually look like this? I know a lot of times they have, other differential diagnoses, and then you're going to say, okay, it's going to look like pneumothorax, it's going to look like MI. And maybe like 3 days later or 4 days later, come and say, okay, let me even look like what separates them. What makes these ones unique? Why are they exactly not PE? Okay. Now, what about tuberculosis? There is a listen, there are types of cough. Just don't say cough. Don't give me cough. Cough doesn't work. You got to pay attention to the type of cough that your exam is referring to. If they say persistent cough, it's not the same as cough. Are you kidding me? I just coughed. That is just not going to tell me anything. So your cough, you have to be descriptive. Don't forget. You have to be very, very descriptive for me to count it. This one is even saying cough with sputum. That is for pneumonia. This one is saying what? Chronic cough. So what I'm trying to say here. So cough is not just cough. Don't give me cough as an answer when I'm asking you for symptoms. Be descriptive, because the attachments to that cough make a big difference. Tuberculosis, they are persistently coughing. Night sweat, fever, weight loss, recent what? Exposure, positive tuberculin test. But those are like afterwards. But what do we even see first? As soon as we lay eye on the patient, it is persistent cough. Persistent. The patient is persistently coughing with tuberculosis. Because it's some kind of infection too, right? Any infection, you are expected to see fever. Night sweat, night sweat will be your keyword on that test. All right? And then you're like, oh my gosh, what can it be? What else can it be? What else can it be is the definition of your differential diagnosis. That is the lung cancer, pneumonia, right? Now, so what makes lung cancer and pneumonia unique though? What differentiates them from tuberculosis? It is what? Lung cancer often lacks fever. You got to hold on to that and give it a beautiful hug. It has mass lesions. Pneumonia resolves with antibiotics. Listen, while tuberculosis has what? Granulomas and prolonged symptoms. Boom. So it looks like some things, but those things also have their own unique characteristic. Listen, it's like I have a mother here that gave birth to 10 kids. Yes, they all looking alike a little bit, but they also have their own unique traits. So we must be able to tear apart diagnosis that way. Speaking is Dr. Kehinde ELISHA, founder of NP Certification Academy, www.npcertificationacademy.com. So look, acute bronchitis, productive or non-productive cough, viral history, no fever, rhonchi, clear with coughing. Listen, we're saying what? Acute bronchitis, you have a productive or non-productive. That kind of puts you in a little bond right there. So for that reason, because it's variable, right? It could be productive and it could not be productive. So for that reason, what does that mean? You won't really count on that. Okay? You will know that it's there, but you can't count on it. You can't say, okay, my keyword is productive or not productive. What if the question only gives you productive? And then you are in doubt. So look for something else that actually, set it apart. So look, we now have viral history. That will be a presentation on the exam. No fever though. Bronchi clear with coughing. So look, let me quickly talk about viral history. Hold on to that. No fever. Hold on to that. And many of us, when we see itis, we are immediately saying infection and inflammation. Remember though, we're saying acute bronchitis. So I guess it hasn't gotten that far yet to result into some kind of fever. Does it make sense? It is still an acute phase. So they have viral history and they don't have fever. They do not have fever. Your case study will say they do not have fever. Okay? So don't still rule it out because you see itis. You're like, okay, when there's itis, there should be fever with this one. Not necessarily. Not with acute bronchitis. I'm emphasizing that. Okay? So now, what does it look like? It looks like pneumonia. It looks like post-nasal drip. So with pneumonia though, pneumonia has fever, consolidation, and abnormal chest x-ray. Post-nasal drip has chronic cough without fever. Pneumonia has fever. We saw it up there, right? And consolidation. You cannot lose sight of those two things. Pneumonia has fever and they also have consolidation. And guess what? The chest x-ray is also off. It's abnormal. So now, let's now talk about pulmonary fibrosis. It's a progressive dyspnea, dry cough, environmental exposures, example, asbestos, fine crackles, restrictive pattern. So now, chronic obstructive pulmonary disease, heart failure are the things that actually like overlap with symptoms that look like it. When we talk about differential diagnosis, we're talking about things that look like it. Listen, remember, at the beginning of the class yesterday, we were talking about the ADPI process. We said if your assessment is wrong, your diagnosis is going to be looking definitely off. If your diagnosis is off, guess what's going to happen? Your planning is going to be out of this world too. If your planning is out of this world, guess what? Your implementation is going to be out of this world too. Then when we get to evaluation, you're not going, initially you're like, okay, wow, they finally got to me. I'm happy. And then you take yourself back to the top, and then you check your assessment, it's off, diagnosis is off, planning is off, and then implementation. Then by the time you know, it's like, oh my gosh, the patient is gonna not make it because we did things wrong at the beginning. So now, what is the relevance of this ADPI process to our diagnosis? Your correct and accurate assessment. Listen, I don't care that you're taking board exam. I care that you learn your stuff, whether board exam or not, because you're going to be taking care of human beings. Don't take this board exam just to pass. I know that's the focus of many students. At NP Certification Academy, sorry, that's not the focus. The focus is when you get it for good. And we are the last person you're going to connect with before you start practicing with real people. So why don't you just go ahead and get it right now? So get your assessment straight. We have a whole content that's so deep. My assessment is so deep, it's like almost the whole textbook. Get that straight first. Now, when you get that straight, you are now able to pick up and say, okay, pulmonary embolism is looking like all of this, but I'm going to go ahead and walk the patient up even further. Now, if you still cannot pinpoint something, it is always okay to go back to what? Your assessment and start afresh to see if you miss something. So what is the differential now for IPF? It is chronic obstructive pulmonary disease and heart failure. So what sets it apart though? Now with COPD, it has an obstructive pattern. Heart failure is associated with fluid retention, while IPF, what shows a restrictive pattern on PTFs and fine crackles. When I say PTFs, what am I saying PTFs? What is PTF? When I say PFTs, what does that mean? Sorry for the abbreviation, but you should know. I'm assuming you're going to know it. We went through this test before too. I didn't bring it in right now, but I can bring it back. Okay, pulmonary function test. Absolutely. We need to be familiar with that. Actually, we went over it yesterday with the one we're going through the guidelines, GINA guidelines. So now, and gold guidelines as well. So now look, let's now go through some pathophysiology. So with the disorder like asthma, pathophysiology, what exactly is the pathophysiology? Like, what is the cause of asthma? We know it's inflammation and narrowing of what? Of the airways due to bronchoconstriction, edema, mucus production, often triggered by allergens, exercise, and so on and so forth. What do I want to tell you right now? If you know your pathophysiology, listen, you're going to know how to diagnose, period. Your exam is about the 3 Ps. Your exam is about what? Physical assessment, pathophysiology, and pharmacology. That is what your exam is about. But the foundation is really pathophysiology, because that will knock 2 things out of the way. That will help you knock your diagnosis out of the way too. So most of us are good with asthma, so I'm going to keep it moving. Let's now look at the pathophysiology of chronic obstructive disease. It is the progressive and irreversible airflow limitation due to airway inflammation, structural changes, and emphysema, often caused by smoking. That smoking, you can't miss that on the exam. It's going to be written and slapped on your face. And the fact that it's going to be progressive and irreversible, don't miss out on it. Can you see how this overlaps with your differential diagnosis? So when I say pathophysiology, you think differential diagnosis. When I say differential diagnosis, you think pathophysiology. They are both connected. All right. Now, what about pneumonia? Pneumonia is an infection causing inflammation of the lung parenchyma, leading to what? Consolidations. Listen, I held on to that consolidation. That's kind of what we're going to see also on what? On the X-ray of the alveoli with pus, fluid, and inflammatory cells. What about the pulmonary embolism? It's an obstruction of pulmonary arteries by what? Thrombus, leading to decreased blood flow, hypoxia, and potential right heart strain. You can breathe, the right heart is strained. So now what about tuberculosis? Chronic infection caused by what? Mycobacterium tuberculosis. You got to know that for test. Mycobacterium tuberculosis. When they ask you which organism is responsible for tuberculosis, Mycobacterium tuberculosis. I am not releasing exam question. I am just being resourceful. Listen. So Mycobacterium tuberculosis is the cause of what? Tuberculosis. And of course, you should connect with that easily anyways, because the tuberculosis is attached to Mycobacterium. So you don't need any mnemonic for that one. Now, what about the acute bronchitis? It's an inflammation of the bronchi, often caused by viral infection. Is an inflammation of the bronchi, often caused by viral infection. Viral infection is the cause of acute bronchitis. So the inflammation is really not coming from bacteria, it's mostly from the viral. That makes sense that we are not going to have a fever with this because it's viral. And it's going to result in mucus production and acute and cough. What about pulmonary embolism? Scarring and thickening of the lung tissue, leading to restrictive lung disease and decreased compliance and impaired gas exchange. Now, this is not all inclusive for your respiratory system, but I promise you, if you know all this and you can articulate all this, you're going to feel good about yourself. That's one of the major organ systems that we deal with. Any questions at this point? If you don't have any questions, we're going to move right on to what? Our mnemonics. Because we cannot, forget our mnemonic lovers. We need to take care of them too. So what is the mnemonic to really capture this diagnosis? It is Aunt Cindy paints pictures to appreciate beautiful paintings. For me, honey, I'm sorry. I'm going to say bye-bye to this one because this is extra study for me right here. But some students, they like it. So let's quickly, for their sake, let's go for it. Aunt is asthma, inflammation, bronchoconstriction, and triggers. What about Cindy? COPD, that's chronic irreversible smoking-related emphysema. Now, what about paint? Pneumonia, infection, consolidation, alveolar. So that, again, is tough for me to still connect with my real case symptoms. So I'd rather go over it and over it and over it is the best bet I think I can recommend. But if you like the mnemonic, it is going to be right here for you. This flashcard, I will quiz you on this next week, okay? And if I don't get to it because I have body systems to cover, I need you to grab even your 9-year-old, okay? You're going to go ahead and cut this into pieces, okay? You're going to cut it. You have those lines, cut it, and then, or maybe I can even create it for you, or you just can create it on a PowerPoint or something. Turn this into PowerPoint, instead of even cutting it, just turn it to PowerPoint, or don't be the one to look at it. Have your 10 to 15-year-old, if you don't want to expose yourself like that, grab somebody in the class and form a study group. Because I know how that goes. If you miss it or you don't know it, they start having this thoughts about you. I told my when he was my son was 5 years old when they had a pandemic at the time, I think, and I told him to teach me something. I wanted to know if he was reading. I said, can you teach me what you learned in class today online? Because I always assume they don't learn anything really. And he started crying. Hey, Tommy, but why are you crying? Mommy, because you don't know anything. And I'm like, what? So anyway, so there is a way their head think that you don't know anything. And I thought it was funny because he thought I didn't know it. And I was kind of asking him to teach me really so I can see if he learned anything or not. But that was just my funny story there for that. So if you're not comfortable with your kid quizzing you, of course, you don't want to expose all your weaknesses to them, of course, find a partner in the class, okay? But I want you to work with this flashcard. If you're a flashcard lover, I'm trying to incorporate all kind of learning styles. Not everybody is visual, not everybody is auditory, not everybody is, I like flashcards. I personally don't do flashcards, but I'm doing it for the sake of my students. I started to bring it to class. So this one is going to say, okay, the diagnosis is asthma. What are the keywords to remember it? What are the things that it looks like? And then you're going to keep going and keep going. And then the one that I like a lot is this one on the bottom. That somebody would probably just ask you, okay, I am seeing somebody with, let me see. I am seeing somebody question, okay, I have somebody with smoking history, with chronic cough, with sputum. These ones I like. Does it make sense? And then you now tell me to figure out what the answer is, and then I will tell you COPD. So if you want to see what you really know, that is not the one on top is a little easy. It's just to get you in and get your feet wet. I need you to go ahead and do this one, this flashcard right here. Or your patient comes in with coughs, with sputum, fever, pleuric chest pain, dyspnea, crackles, consolidation on X-ray. We went through content already, right? We know it's for sure pneumonia. Consolidation, you say pneumonia. When I say consolidation, you say pneumonia. Now those small things are the things that will really matter on the exam. When I say pulmonary embolism, you say hyperresonance. Of course, you can also say sudden chest pain or sudden dyspnea as well. So, and then the flashcard here talks about what condition and symptoms is likely indicate. What are we talking about here? Yeah, patient comes with persistent cough, nice sweat, fever, see that? Automatically, you know this is tuberculosis. If you want to do it yourself too, that's fine. But this would be nice with a pair. The answer is right here, so there's no point in me quizzing you on it right now. Maybe when we create flashcard on it, we can bring it to slides on it, we can bring it to class. Now, the last thing I want to quickly talk about is this flashcards about guideline. Remember, we have guidelines that support all conditions, most conditions. We just don't do guesswork. There is no guesswork in medicine. Listen, what we do is about evidence-based. So let's keep that in mind. So what does that mean? So that simply means, there are guidelines, and we went through the guideline yesterday. So I brought in the guideline, the flashcard right now. And what is today's date? This is February 20th, 2025 at exactly 11:05 a.m. But last night around 9 p.m. or 9 p.m.-ish, we went through the guideline. Yesterday morning too, we did. So, and then you can also reinforce it again before you do these flashcards. And it's asking, what is the main goal for asthma management according to GINA guideline? And then it's going to tell you, okay, this is it. And it's going to give you the answer. Then you should be able to articulate all this. And then another guideline says, question says, what are the two main components of asthma management in GINA? And then I'm going to give you the management and so on and so forth. And it goes on and on just a little bit, and that ends it. Then I have a beautiful summary here. Steps for poor asthma control. So if you have a patient and they are not really doing well with their asthma control, check, are they adhering to the treatment? I reassess asthma phenotype. Allergic versus non-allergic. You want to know exactly what the cause of the asthma is, or what is the origin of the asthma. Review trigger management and educate on avoiding common triggers. Adjust medications by increasing ICS dose. If symptoms persist despite appropriate management, you want to refer to what? To specialists for further what? Evaluation. Okay. All right. So that is that. For that, I really hope you've learned a lot today. And then if you're talking about referrals too, if you're worried about, okay, when am I supposed to refer? Well, when things like, you would know when you're supposed to refer. For example, when things are very, very tight, you know you can't get anywhere, you know it is beyond you, surgery is involved, you know it's time to refer. FNP, AGNP, AGACNP exam is a lot of work, but it's very, very doable. As long as you're going through your hard process, and as long as you're not giving your guidelines behind, and as long as you're willing to work. It is a lot of work, but guess what? Together as a team, we will support you, and you're going to pass your test. You're going to pass your board exam. And the lungs and blood, I think, okay, I'm seeing things, okay. So that is it. Do we have any questions at this point? Okay, if we don't have any questions, I'm going to wrap this up. At this time, we're going to quickly guide you on our website. If you want to sign up, www.npcertificationacademy.com. My phone number is right there, 347-901-6037. Email is right there, info@npcertificationacademy.com or nurse-to-nurse-coach@gmail.com. To join our Facebook, just go ahead and click on that little thing that says Facebook right there, and it will take you right to our group. Next, click it to see what happens. When you click on it, it brings you right in here. This is a group that you want to belong. You see green checks, you see people passing their tests. Make sure you're joining the right group. There are many scammers out there. Stay safe. And they will be trying to solicit, trying to get money out of you. Please don't do it. See that right now. This one is advertising. I'm about to check them out and delete and ban them permanently from the group. That's what we have to do to clean up and keep our members safe. Our schedules are also posted in the group. We post so many events, so many activities. We have this event happening very soon as well. March 16th to March 29th, we have a conference on how to help people set up their business coming up. Our schedule is right there. We also post questions and answers for you to actually assess and do on your own. We have pharmacology updates coming up February. Actually, that was passed February 17th. So you're gonna be a lot of benefits being in here. But hey, our review, if you're not ready to learn, don't even bother. You're gonna be learning your stuff and passing your exam as well. You know, the community is fierce right now when it comes to jobs, and of course, when it comes to actually being the best, you have to just put in your best. You come in here to sign up. You click on FNP, AGNP, AGACNP is also here. If you want to sign up, then you click on the exam. You pick whatever you want. Again, we are at 99.9% pass rate. You want to give us a try? We'll look forward to having you in the group. Dr. Kehinde ELISHA speaking here, founder of NP Certification Academy. And of course, you can find us 347-901-6037 or email nurse-to-nurse-coach@gmail.com. Of course, you can also visit our website and always do your research. Before you drop your money for any review, always do your research. Don't waste your money and be regretting it. Have a wonderful day, everybody, and have a beautiful February. It's February 20th. It's snowing out there. Please make sure you stay safe. Have a wonderful day. Bye-bye.